Welcome to this Learn at Work webinar. I'm Karen Jacobs, and I'll be the moderator. I'm the founding editor of the journal Work, a journal of prevention, assessment, and rehabilitation. Our journal is published by iOS Press in the Netherlands, and I thank them for their support. I'm going to turn this webinar over to our two speakers, and they'll introduce themselves, and we'll have time at the end for questions. So welcome, and the webinar is all yours.
Thanks so much, Dr. Jacobs. I'm Rhonda Robert. I'm one of two presenters today. I'll be co-presenting with Dr. Teresa Ann Granger. I'm from the University of Texas MD Anderson Cancer Center in Houston, Texas. And Dr. Granger is joining us from the University of Alabama. We would like to talk to you today about factors contributing to financial distress in young adults with cancer. Specifically, we'll be looking at material resources, health status, both physical and psychological, as well as workplace variables. I'd like to also acknowledge our other authors, our co-authors, because we represent several sites. Also from MD Anderson is our vocational counselor, Sandra Medina George, and our biostatistician, Mr. Clark Anderson. We work closely with the American Institutes for Research and their faculty, Dr. Melissa Scartaville and Dr. Kathleen Murphy. They are both experts in disability research and variables that contribute to vocational rehabilitation. We work with the Southwest Americans with Disabilities Act Center, as well as the Independent Living Research Utilization Program with TIER Memorial Hermann. And our collaborators there are Mr. Vin Nguyen, who is a legal expert on disability and employment law, and Dr. Lex Friedan, who is an expert in legislation and advocacy. The main message of today's presentation pertains to financial distress. Through our research, we have learned that financial distress is a primary concern for young adults with cancer. They have very particular vulnerabilities, these young adults. Many of them lack parental financial support as their health crisis occurs after they've transitioned to adulthood and have left the family unit. They are typically early in their career, and being early, they don't have the workplace benefits of the senior members, nor the status. For example, they don't have longevity or tenure. They have a high symptom burden. Most of the young adults with cancer identify significant symptoms that interfere with daily living, and that severity extends to interference with work performance. It also interrupts their income generating potential through work. They have absences for health related reasons. They may be reassigned different work tasks or lose projects, essentially decreasing their income generating possibilities, and some actually lose their jobs during the course of treatment.
Thank you, Dr. Robert. So as Dr. Robert was explaining, unlike adolescents, young adults with cancer may not have parental financial support during their cancer treatment and rehabilitation. and young adults are just emerging in the workplace and do not benefit from the lengthy tenure in their employment compared to older adults with cancer. So these young adults are in this precarious space where they are trying to establish their careers and may not be fully financially stable relative to middle-aged and older adults. The symptom burden from cancer and cancer treatments affect 2/3 of the young adult patient population and oftentimes negatively interferes with work performance. The financial issues of young adults with cancer have been associated with several negative outcomes, which include barriers to accessing medication, adhering to medical treatment, the symptom burden, quality of life, emotional distress, and survival. We aim to explore material resources, physical and psychological health, and workplace variables associated with financial distress in young adult cancer survivors to better understand and further define the multidimensional model of financial burden. The definition of financial distress that we adopted is from Salzman and colleagues, which is defined as a subjective measure of the impact of financial burden on patients' well-being, captures the affective experience, and reflects the extent of worry, anxiety, or anguish about financial burden experienced or anticipated. Financial burden is a related but distinct construct within the definition of financial distress. And this has been defined as a relatively objective measure of personal financial status, defined as the ratio of total out-of-pocket spending on health-related costs to total household income. For this study, we conducted a cross-sectional study using an online cancer survivor employment needs survey. All participants would be between the ages of 18 and 39 years, which aligns with the National Institute of Health's definition of young adult, residing in the United States, and they had to have a cancer diagnosis other than non-melanoma skin cancer. The Cancer Survivorship Employment Needs Survey is a 49-item measure that was adapted from an existing British work in cancer measure to fit a US cohort. The self-report survey consists of 6 scales regarding cancer side effects, the effects of cancer on work attendance and productivity, the effects of disclosing cancer at work, the provision of reasonable workplace accommodations, knowledge of available cancer-related resources, and knowledge of employment-related federal legislation and programs. The survey takes approximately 20 to 25 minutes to complete, and because it was offered in an online format, we were able to use skip logic to alleviate response burden so that participants would only answer questions pertinent to employment and disease status. To measure financial distress, we used a financial distress item from the self-report survey, which was phrased as, apart from concerns about my health, financial problems caused by my cancer have created more stress for me than anything else. This item was rated on a 5-point Likert scale, ranging from strongly disagree to strongly agree. To analyze our data, multivariable linear regression was used to separately model relationships between financial distress and responses among 4 of the selected scales, each of which contained items that address material resources, such as personal income expenses and employment benefits, physical and psychological health, and workplace factors, including accommodations, disclosure, and stigmatization, while adjusting for potentially prognostic covariates, gender, race, age, time since diagnosis, and education. We selected these socio-demographic variables that might confound the associations a priori through a review of the literature. And these again were gender, race, age, years since diagnosis, and education level. Our participant sample included 214 young adults with cancer. The sample was mostly white females and representative of 39 US states and 2 territories. Most participants had at least an associate's degree for education. The mean age was 31 years with a standard deviation of 6.3 years. The mean age at time of diagnosis was 26 years with a standard deviation of 8.7 years. And the mean years that had passed since diagnosis at the time of the survey was 4.6 years with a standard deviation of 5.8 years. Delving into our results, we found financial distress was prevalent among our sample, as 59% reported financial problems caused by cancer created more stress than anything else.
Thank you, Dr. Granger. I'd like to share some more regarding the associations found between financial distress and the variables we've discussed. All variables were looked at individually in a multivariable regression model. In regard to expenses, personal expenses associated with financial distress included estimated out-of-pocket costs. So these would be costs that would be new and much different from the pre-cancer household budget. Also associated with financial distress was short-term disability leave. Long-term disability leave was not associated, and there are different levels of access to these in the workplace. Personal expenses, those associated with the pre-cancer household budget, were not related to financial distress. In regard to physical health status, we saw several associations. Those included concerns about effects of diagnosis on ability to work, job demands becoming too stressful to be handled, job being too physically demanding for work to be continued, as well as pain and mobility impairment. And mobility impairment, specifically navigating the work environment. We also saw 2 trends. We saw that physical changes were trending towards significance, and physical changes included visible distinctions such as hair loss, as well as the use of assistive devices. And examples provided in the item were walkers, canes, and wheelchairs. Other treatment-related sickness or symptoms were associated with financial distress. And given the breadth of illnesses and treatments that occur under the umbrella of cancer, these are widely varied and can be extremely significant. We did not find association with some of the more common symptoms such as fatigue, nausea, and difficulty concentrating. And that's very interesting, right, to note, and also something that may be addressed through the supportive and palliative care experts. In regard to psychological health and its association with financial distress, we explored both depression and anxiety. Depression was significantly associated with financial distress. Anxiety was trending with a p-value of 0.052. In regard to workplace accommodations, several of the accommodations were not associated, but two that trended are noteworthy, and those are a flexible work schedule, and that trend was at a p-value of 0.09, and enhanced accessibility to information technology, and that p-value was at a 0.05. The others were not associated. In regard to stigmatization following the cancer diagnosis and disclosure, we saw both associations as well as lack thereof. We did not see concern about the individual disclosing what's going on with them health-wise. However, the implications of sharing that diagnosis are what really were stigmatizing. The following were significantly associated: lack of emotional support at work regarding the cancer diagnosis, stigmatization, feeling left out, stigma of, and the behavior of being omitted from activities, reduced satisfaction in employee-supervisor relationships, reduced satisfaction in coworker relationships. They're also feeling isolated. Perceived treatment of being incompetent, having duties reassigned, and having workloads reduced. Many noted a receipt of negative evaluations after having taken leave from work or having health-related absences. Some lost a promotion or were passed up for a promotion or a project. Diminished career prospects and job transfers were noted. And many said that they did not explain their job performance or maybe interference with performance due to health for fear of losing the job. Also associated with financial distress was concern that the employer would not hold the job if leave was taken. There was also receipt of subtle pressure to resign, take leave, or retire. And associated also was the employer asking the employee to resign. We also have a trend of being fired, and that p-value is a 0.09. So in summary, financial distress was prevalent in this sample of young adults with a cancer history. That was at 59%, and an array of problems were associated with financial distress. In regard to the implications for practice, we see from this that financial health is an essential element of young adult cancer care, and that those of us who are providers in oncology and rehabilitation are suggested to discuss finances with young adults, to guide them to resources that can address financial need, benefits, workplace benefits, and vocational needs. aiming to optimize quality of life. We also believe that there are labor and healthcare policy implications, and perhaps information from this may help encourage workplace protections, including the protections of healthcare benefits. In regard to study limitations, this is self-report, so there's the potential for bias or inaccuracy. This was not a randomized group. They were quite heterogeneous as participants, being from across the nation. There were 2 decades of lifespan represented, from 18 to 39, and they did not represent our international population. It was solely the United States residents. And these are associations with the analyses conducted and not establishing causality. So we'd like to thank you for joining us for this webinar, and we'd like to encourage discussion.
Hi, took me a little bit to unmute myself. Thank you so much. This was so interesting. It's a population that I have not worked with. And I want to ask what it's like to work with this population.
This is Rhonda. I'm glad to start that response. Would that be okay? So I'm a clinical psychologist here at MD Anderson Cancer Center and do work in the young adult cancer program. And I think, and I did not, I entered this and started working with this population mid-career and had no previous experience. So one thing that really took me back was the duration of the treatments. And I think that might be also seen in the some of the articles and information that's quoted in the introduction, is that as long as many as 18 months after diagnosis, 28% of patients are not returning to the workplace, right? And I think part of, I mean, that could speak to many variables, but one variable is the duration. So, for example, leukemia treatment is a 3-year treatment, and that might put some perspective on why we're talking about the world of work, because this isn't a brief illness course, right? So it's very long. And also I'm astounded by the level of symptom burden, right? So most people know about brain fog from chemotherapy, as we saw that, you know, there's the issues with attention, memory, and speed of processing new learning. Most people know about nausea and hair loss, but that's only the tip of the iceberg. The treatments, the illness, they can be extremely debilitating. And I think the appreciation for that severity and breadth is something to also contemplate when we're thinking about work, career, and vocational rehabilitation. A lot is required in regard to supportive care and management of long-term symptoms, right? So we have not only symptoms during active treatment, but the long-term symptoms, they remain, some of them remain from the active treatment, and some actually occur as time goes on, with this population having symptoms as they age, and they have these symptoms more readily than we would if we were aging without having had this illness. That's what comes to mind immediately. Yeah, you're welcome.
Teresa, how about yourself?
My background is in rehabilitation counseling. And through rehabilitation counseling, we support individuals with a psychosocial adjustment to disability for those with chronic illness and disabilities. We also, I was trained in vocational rehabilitation. I have not specifically worked with the cancer population as a clinical focus, but it is a research interest for me because in the vocational rehabilitation services, and those are across all of the states and United States territories that provide these services to get people back to work, cancer is underrepresented as a primary disability type. And in 2008, the Americans with Disabilities Act was revised and opened up the definition of disability, which includes individuals with cancer. And as Dr. Robert mentioned, they have long-term effects and long-term disability as a result of their cancer or their cancer treatments. And so my interest is in getting them involved in the vocational rehabilitation services so that they can get back to work and do work that is meaningful, but also provides them the financial stability as they're trying to bounce back from cancer.
Oh, thank you so much. So people listening to this webinar who want to better understand, perhaps from an employer perspective, what would you recommend them doing to become more knowledgeable and perhaps encouraging for this population to come work for them?
I think supervisors should consult with their human resource departments if that's a resource that's available to them, because those HR professionals should be knowledgeable about the benefits that individuals with cancer would have access to in the workplace, as well as relative laws and legislation that would protect these workers.
Okay.
So supervisors taking that step to just become more knowledgeable would be helpful so that they can better support workers with cancer. But just recognizing that they may need some reasonable accommodations,
Yes.
possibly flexibility in the workplace, but these workers are eager to get back into the workforce and have meaning in their life once again.
That's wonderful. Thank you. So just my last question that I'd like to ask you is, what's next? You know, I always think about if money wasn't a concern for conducting research, what would you want to do next?
Well, this is Rhonda. One thing that comes to mind, and it's on the cusp of what we were just talking about, in regard to how the employer can be helpful. There are a lot of behaviors that tie in with these items that we discussed today, right? Where it wasn't the disclosure that was difficult, but it was how people, the implications of that disclosure, how people treated them day to day, including the supervisor in the workplace group, right? With a lot of that omission and negative thinking around their abilities. And what we are going to report on next, it involves the same study, but we asked people, what was most helpful? What was the most helpful thing that your employer did? And it's remarkable, and it gives me the chills just thinking about it, when they described, and this is a narrative, when they described what the employers and the coworkers did for them, that would just bring you tears to your eyes or give you goosebumps in regard to the camaraderie and the positives. We also asked them what was hurtful in regard to what individuals, including coworkers and supervisors or leadership, did. And there were some very pointed actions that were found detrimental or deleterious to their well-being in the workplace. And so that's one thing that we hope to report on more immediately. But maybe Dr. Granger, you're also thinking and beyond that. Any thoughts there?
Sure. I think vocational intervention may be a next step for this population. Identifying ways to educate employers, how to accommodate individuals with cancer in the workplace, educate them on the relative laws protecting these workers, and also addressing some of those responses. If cancer is disclosed, how might I respond? On the consumer side, providing job support, providing interventions that will help them get back to work or resume the best work capability that they can relative to their current functioning.
Yeah, great. Thank you. Thank you. You know, a place that I turn to quite a bit is the Job Accommodation Network, JAN. And have you had any experience with working with JAN or sending, people for information there?
I've had experience with JAN. Yeah, Dr. Robert, have you?
No, I'd like to hear some more if we have room for that today.
Yeah, so the Job Accommodation Network, you can find it with a search, Ask JAN, and it provides information based on many different disabilities under what they call a SOAR, and they have lots of information on accommodations that can be made, and I would encourage any of the people listening today, if you have a relative or you are the population that's been discussed, to go there and look at what resources are there. It's free. It's out of the West Virginia University, and it has invaluable resources for people.
It's a really wonderful resource. I've used it in the workplace. I've used it in vocational rehabilitation practice. And I also teach about JAN to my students, rehabilitation counselors in training. And I have them do some, exercises around that to become familiar with that resource. You can look up most disabilities from A to Z. They have that resource on their website, and
Yes.
It'll provide a list of accommodations that may be useful. And it's a great tool to review with individuals with disabilities to see what they think might work well for them, especially when they're unsure. They know they're not performing at the highest level or as expected by their supervisor, and some of those accommodations have really been helpful in my practice.
Oh, I'm so glad that you're using it. I'm an occupational therapist, and I use that resource on a regular basis too. And I think more people that hear about it, I think it's going to really bode well with helping people advocate for themselves as well. Well, thank you both for being guests on Learn at Work. We will have the link to this webinar available in the next few days on our workjournal.org website, and it'll be in our YouTube channel, on our YouTube channel for Learn at Work as well. And thank you both for taking the time to share the work you're doing, and it's important work, and you're making a difference in a vulnerable population. So thank you again.
You're welcome, and thank you, Dr. Jacobs. This was a wonderful opportunity to meet today and discuss this important subject.
Thank you. Well, everyone, have a meaningful remainder of the day.